Good evening, everyone. Welcome to Alumni University. We're so happy to have you join us tonight. My name is Kristen. I'm the Director of Constituent Engagement here at Illinois Tech, and we are so happy to have Kim Erwin joining us for this month's presentation. So just a few housekeeping notes before we get started. Please note that this presentation, including the chat, is being recorded and will be available on our website in the next several weeks. Additionally, if you have questions throughout the presentation, please type them in the chat box at the bottom of your screen, and we will do our best to get them answered at the conclusion of tonight's presentation. So to introduce our presenter, Kim Erwin is an Associate Research Professor for Healthcare Design at the Institute of Design here at Illinois Tech. She's an expert in healthcare design. She applies design methods to complex systems and develops novel solutions to address healthcare's frontline problems. Since 2010, she's participated in or led more than 60 panels, presentations, and workshops throughout the United States. Additionally, from 2017 to 2020, she served as the Associate Director of Population Health Sciences at the University of Illinois, Chicago. She has an undergraduate degree from Loyola University and a master's from here at the Institute of Design at Illinois Tech. So with that, I will turn it over to Kim to get us started.
Thank you, Kristen. It's always interesting to hear how people introduce me. Okay, I'm going to jump into some slides here. It's better than looking at me. First of all, thank you all for joining. I think it's a gift when somebody decides to spend an hour with you. So, your fellow alumni. And I tried to gear this to be useful for both design and non-design audiences. So as Kristen said, I am an associate research professor at the Institute of Design. I'm also a visiting scholar at the University of Chicago Medical Center, which is particularly relevant to this presentation. Just, because we're all alumni here, my alumni journey, I graduated with a Master's of Design in 1994. I thought twice about actually putting the year, but I decided to include it. I went through over 20 years of management and innovation consulting. Probably before that was a really cool thing to do. Returned to the Institute of Design as a professor in 2007, was tenured 6, 7, 8 years later. And as Kristen suggested, I was then, I actually started my healthcare work in 2013. I became director of the Center for Collaborative Healthcare Design, which is sort of a lab for healthcare and design at the Institute of Design that I built with the research funding that I had collected. And then was recruited to UIC to co-found and co-direct a new lab called the Institute for Healthcare Delivery Design, which is really sort of merging design and healthcare sciences and creating a delivery science lab there. So from that, I think for the non-design audiences, this is a kind of a standard thing I have to say. This is not the kind of design that I do. And it's not the kind of design that the Institute of Design teaches people to do. Beautiful objects and fashion are delightful, but that's not the focus of the program. It's much more helpful to situate the field as focusing on the experience of systems, products, technologies, services. So human-centered design is an experience, and this is an example that I like to explain, which is that, it used to be that when you showed up at a restaurant, you had to wait in a long line to get seated. Now they are giving you little devices like this, so they're texting you so that you can actually wander off and grab a drink at the bar and enjoy yourself, or wander down the hall if your restaurant is located in an interesting building. So these are the sorts of touches that is a very superficial example, but it's a thoughtful touch that creates an improved experience of something that otherwise is fairly typical. This in the West Coast world has been classified as what they call invisible design. Invisible design being the idea that we're no longer designing stuff you can touch, but we are designing experiences that integrate different technologies and products together, software, and then creates a wrap around that is usable, desirable, and feasible for end users. So again, it's all industry focused. And so the goal of design coming from an industry focused field is to create new products and create new market opportunities for the private sector. It has recently migrated, not that recently, but certainly in the US, it's more recent, design has migrated into fields of civic design and healthcare design, topics that are more complicated and have vastly less stuff involved in them. And the goal there is not to create a competitive advantage. It's to create something that works for real people and changes the direction of the future. In healthcare, I thought I would show you a case study here. It's probably the easiest way to describe what design can bring to healthcare that doesn't already exist, given that it's one of the largest industries in the United States. Why does it need more help? Anyone who's been in healthcare probably has an opinion about why it needs more help. And most of your providers would agree with you. No one thinks it's working. I have worked in health systems all across Chicago and with researchers and providers across the country. And there is a consensus that despite the incredible mission orientation of healthcare providers and their incredible amounts of education, they come to work every day, but no one's convinced that the systems that they're being asked to use and the care they're actually being delivered or asked to deliver meets the thing they thought they were going to do when they went to med school. And nor is there a lot of belief that simply doing more of the same is going to improve the situation. So I got a text one day. This is a text from a provider who was familiar with my work and said, could you illustrate how blood clot forms? It's not your everyday text. And I was like, can you say more about why? And he says, well, we need to help hospitalized children avoid blood clots. I'm like, why don't you give me a call? I don't really know the straight line between this illustration and what you're trying to achieve. So he calls me, and what I learn is something that I think that I encourage designers in healthcare, and I encourage anybody who's in healthcare to recognize that, even though the mission really was not about creating an illustration for children, it was about VTE prophylaxis, which is a medically specific term for blood clot prevention. How do we increase blood clot prevention activities among hospitalized adolescents, especially with sickle cell? And so the more we talked, the more it became clear that blood clots in any hospital in the US are the #1 cause of preventable death. And it is preventable. And so payers like Medicaid and Medicare will not pay you if your patients are developing blood clots from preventable causes. Typically, if you're in a hospital bed, the prevention is movement. It's a very simple idea. However, in this particular hospital, they have a disproportionate share of their patient census, as they call it, the number of people in their hospital, have sickle cell. They are a sickle cell center in the state of Illinois. And if you are in Medicaid, they are really the sickle cell center because of their research base. So patients with sickle cell, it's a blood-borne disease. If you remember your high school biology, sickle cell is when your red blood cells are no longer ovals. They don't flow past each other in the veins and arteries and interchange mechanisms in your body. They turn into half moons. And when they turn into half moons, they start to collect and click onto one another, and they create occlusions in your veins and in your blood system that can cause strokes and blood clots and cause significant organ damage. Sickle cell is also genetic. If both parents have it, you've got it. And it doesn't come on slowly. You have it from the day you're born, and it's very common for children by the time they're 8 to have had a stroke, to have organ damage. So it's a terrible disease. I've done a fair bit of work with sickle cell patients. And in this case, in the hospital setting, sickle cell patients are 2 to 8 times more likely to develop blood clots. And in fact, in this particular hospital setting, 1/3 of the blood clots were people with sickle cell. This is a problem. It's a leading quality indicator for hospitals, and quality indicators are how you get paid, and they are how you get ranked. So the decision by leadership was to task nurses with improving patient compliance, that is an indicative of word, to engage in prevention activities such as movement, hydration, and there's not really a lot else you can do, but those are a couple of things you can do. The leadership decided that the way that was going to happen is that they were going to borrow an evidence-based program from Johns Hopkins. Now, you can't read that chart, but you don't need to, because it is full of facts that are meant to engage the rational actor's mind. If you just put the right facts in front of people, maybe they'll actually do the right thing, even though plenty of research tells us that's not how human beings work. The Hopkins model that was here, they got a grant in 2013. They developed this program. They put it through tests and had significant improvements in the outcomes for people. In other words, they got fewer blood clots. And the pediatric staff took one look at this and said, this is not an appropriate use for children. I'm not going to present them with a table, hence the request for an illustration. So this was a hospital-led initiative. It was coming from hospital leadership and the quality improvement people. You have to know that in healthcare, it's an evidence-based field. If there's something they're going to address, they're going to go find something that has some kind of evidence base behind it, which this does. It doesn't fit the context of use here, but that is not how hospital systems think necessarily. And the reason for this are these three groups on the side. CMS is the Center for Medicaid and Medicare Services. They are the payers. They pay you based on the performance that you can show against quality indicators. Vizient it's a nationwide group. 97% of academic medical centers are partners or members of Vizient. It's a healthcare quality performance group. And what they do is they track stats. If you're a member, you send them your data, they turn stats into numbers, and those numbers make you look good, better, or worse. The Joint Commission is an accreditation organization in the United States. If you are a hospital or you have a hospital program, it has to go through Joint Commission review in order to be accredited. These three groups call the shots. And so this is something I don't think is obvious, and designers are not necessarily trained to be able to see these factors, that money and measures, which are what these three organizations, and there are others, but those are the three big ones, create hospital level priorities. Hospitals do a top-down determination of programs, and programs drive the practices and the performance metrics around those practices. So although you and I can be involved in a hospital experience that is self-evidently deficient, substandard, unsatisfying, the fact of the matter is that this is a web of forces that hold that current experience model into place. And if what I often encounter, as I did with this particular physician, is they are looking at the problem in front of them, and that's the problem they want to solve. They're tired of dealing with it every day. And so they might turn to a designer to say, this is a problem, can you help us fix this? But the designers and everyone involved needs to understand that in order to focus on this, you have to move upstream to these other components. And that in doing that, you need to learn to design for constraints. So all those industry-based practices, which are really focused on being inventive, they are focused on finding new needs and new opportunities, and they are about creating the new. Here we are not likely to be creating the new. We are creating something that can function within constraints, because those constraints are really the boundaries of our problem. We can't see them, but they're there. And that means that designers are really need to be trained in health systems by trial by fire, are learning to create systems aware solutions. We are not designing the system, but we have to be aware of how the system functions, what's upstream and downstream, and to be able to incorporate that into our project planning and our problem framing. So whether that's not just true in the hospital, it's true in outpatient settings, your primary care settings, your specialty care settings. It's also true at the community level. All of these forces are at work. And if you are focusing on a health-related topic, these forces are things you need to pay attention to. And these are the forces that I was engaging with as I was responding to the request for a blood clot illustration. What we decided to do was a 6-week pilot. So this was a multidisciplinary team. You can see me in the upper right. We worked with hospital operations over on the left and the pediatric quality leads. We also worked with medical students. We decided to do sort of a joint effort between the hospital's med students and the design students at the Institute of Design. And we engaged in a 6-week kickoff to develop a point of view about what a better intervention would be than the Johns Hopkins table. 6 weeks, I think, is another, that kind of rapid turnaround is that agility is something that design can offer to healthcare that it doesn't actually normally have a capacity to do in and of itself. So we did a number of things. One of the things we did is try on these delightful devices called interneumatic compressive devices, IPCDs. IPCDs are, they're squeezy boots. They put them on the calf and they pump through air pressure. They create circulation in the calves. And we wanted to understand what the burden was or might be from a patient perspective. Why is it that these were being rejected by adolescents all throughout the pediatric ward, but especially among sickle cell patients? And so were they painful? We didn't know. We'd never worn one of these. So putting these on, we really realized that they are pretty gentle. We actually suggested they be called massagers, because what we learned in doing this is that the nurse walks up to a child and says, "Do you have your ICPDs on?" And, I just don't think that's a strong sell point. It seemed like an opportunity for a reframe to make them seem more appealing to young minds. We also did observations and rounding. So we joined the resident and attending in the rounding on the pediatric floor. We had been told that promoting blood clot prevention was something that attending physicians and the residents were doing. We never saw it. So it was interesting to note that although that was the goal, it was not happening. And it's understandable if you are a physician and you have a sick child in front of you, or a child's facing surgery, you have a lot of things you're trying to run down as you're trying to get to every room on the floor. And that blood clot prevention is just not making it to the top of the list. This is why it's falling to nurses. We also watched nurses moving up and down the floors and observed the things that they were carrying, how many times they were moving. They're very active. They are very mobile in their people who work in a specific building. They're highly mobile. And realizing that there's a lot of materiality in nurse care. And what I mean by that is there are a lot of products they're moving in and out of rooms. They are constantly running back and forth. And what became clear is that giving them something to hold in their hands to go in and educate patients with was probably not going to be well received by the nurses. They have too much stuff to carry as it is. And they're going from room to room, and the opportunity to misplace it was going to be a challenge. We did staff intercepts, which is just sitting down with people when they have breaks for 10 to 30 minutes. We prototyped immediately. You could see things on the table here. There were early ideas we had. We knew they were wrong, but we also knew if we were going to get lucky enough to spend time with a clinician, that we should have something to show them, because when you show them something concrete, the conversation changes. They'll be like, "Oh no, we don't use that word," or "I would never use this. This is not appropriate for me." That's the kind of feedback you want to know at the beginning, not at the end. So staff intercepts were part of our iterative design process. We also talked to subject matter experts. Sarah Horton was a physical therapist at Kaiser Permanente who specialized in pediatric physical therapy, and Pamela Gampetro also focused on developmentally appropriate care for adolescents. And so these people really helped us understand what's within the range of reasonable when you're dealing with children and adolescents. And then maybe to state the obvious, it seemed inappropriate to imagine that we would go in and interview children in their beds, especially without parents there. That's just not an appropriate thing to do. So what we did instead is to recruit patients or people who have sickle cell disease, and we brought them in and spent like an hour and a half with some of them. These patients told us what it was like to be ill from the day you were born. And this patient in particular, he said, "I try so hard to be normal. Like, I know I'm going to have a sickle cell crisis. I know I'm going to be hospitalized routinely. So I strive so hard to be good at science and have sickle cell disease." Like, he doesn't want the sickle cell disease to be the identifying feature of his life, which turned out to be a pretty helpful insight in relating to adolescence. We did lots of prototyping. We did a lit review of materials, looking for sickle cell materials that were appropriate for adolescents and not for adults. They didn't exist. So it was definitely a gap. And then we started looking analogously for other tools that had been designed for adolescents. And we brought behavioral design principles. Behavioral design is the concept of nudges. You've probably heard, thinking fast and slow. The question is how do you use other methods than just usability to create behavior change on the part of the people who are being asked to use a tool? So out of the 22, we ultimately selected 6 for pilot testing. These are some concepts we set aside. We had a goal setting worksheet, which seemed to fit the desire of nurses to get patients to self-identify and commit to doing certain things every day. We created these cards down here that sort of turned different mobility efforts into a game. We created some movement exercise sheets that were sort of inexpensive to produce and could be, because of infectious disease control purposes, you can't reuse them. None of these made it into the final cut, but they were concepts we identified. We took the 6 concepts that seemed to be rising to the top, and we went and showed them to each of the clinical staff we could find. On the right, you see there's an A and a B over these. So these were 2 versions of a poster that we had created. We did some A/B testing. Interestingly, we had 100% agreement among the staff that the poster on the right, the B poster, was the right poster. Everybody laid eyes on that, and just hold on to that because it becomes important in a second. And then in the process, just being on the floor and engaging the staff and showing them things and showing them better things after reflecting their input. What we were also doing is preparing the organization to actually pilot this. It wasn't an explicit goal, but it was by saying, you get a different response when you show something to somebody and say, how do you think this works for you and your colleagues, versus saying, you might have to use this on Tuesday. All of a sudden the scrutiny level goes way up and you get better feedback that way. So we used the pilot to kind of accelerate critique and refinement, and then also to prepare people for actually using these things. Then we put our elements into place, and we thought through everything we had observed. Nurse workflows, what we ultimately concluded on the right-hand side, and this was based on an observation that the people with the most capacity to do anything are the people stuck in the bed and their family members. So adding one more task to a nurse list when they have so much work to do, they are bedside. They are, in a surface logic way, the right people to be taking on a task like promoting adolescents to engage in movement. But the dynamic had proven to be counterproductive. I would say it was creating an adversarial relationship between the nurses and the patients who were not complying. And the nurses kind of were left on their own devices to try and promote this work. So rather than trying to create yet another workflow where they had to go in and educate patients, we tried to put the information to take care of yourself right in front of the patient and right where the family sits. So every bed, there are 4 beds in a room. This poster was designed to be read in dimly lit conditions and was placed within 4 feet of the patient's eye level. So with that, sort of a summary slide of all the things we did. These are the things that we learned. Adolescence isn't a good time for anything. I don't even think I needed to do a study to learn that, but I think what we did here is that this is a difficult age group for developmental reasons. They are trying to be independent, they are trying to find themselves, and they are trying to exert control and mastery over what they do. They are tired of their disease. These are people who have been in and out of the hospital since the day they were born. And one of the things that we observed on rounds is that children who were coming in for sickle cell pain crises, which is when all those cells occlude, they create incredible pain in their bones. And in different parts of their body. And when they come in with those pain crises, their rooms aren't decorated. They are, in rooms where other children, it's unusual for them to be in the hospital. And so people bring them balloons and they bring them cakes or stuffed animals. And that was not happening with sickle cell kids. It was so routine for them to be in the hospital that they were kind of left on their own. They also had fewer visitors. It turns out mobility, so you're sitting here going, well, we're going to promote mobility. Well, how much mobility? There are no mobility standards, despite the fact that it's considered, critical to blood clot prevention. So the lack of standards is not a hospital problem, it's a nationwide problem. These are 2 Wii's that the pediatric unit had. And what they would do is they leave them in the teen room, or they would wheel them into the patient's room. And we were asking, well, what if a patient could walk to the teen room, would that qualify as meaningful movement and kind of, allow that checkbox to be crossed off? These are the sorts of issues that we had to grapple with, which is that everyone knows it's a problem, but the science isn't necessarily 100% there yet. Not surprisingly, then there was a lot of practice variation between the clinicians. So nurses did more to try and create adherence with wearing the massagers and to chart those in the patient chart, and some did not. So, the idea that this was going to become a standard of care, they were pretty far off from it. The real issue is the lack of inclusion of nurses themselves in the decision to how to address this issue in the pediatric ward. They were told, handed down from the top, as is often the case, that they were going to be the front line on constantly promoting and documenting whether or not patients were engaging in preventative care. They not only bear the burden of promoting it, they also bore the blame when it didn't work. There were protocols in place. If a nurse corrected a patient and told them to put on their massagers and the child said no, they were supposed to call the attending. And what the nurses kept telling us is attendings don't respond to our call. They didn't have any backup. They were the front line, but they were also the end of the line. So the question for us was, how do we make it easier for nurses to do this? That's how we came up with this poster concept, which is let's put the information in front of the patients. It's not going to solve not all the patients are going to apply, but we suspect that at least it would take care of some and reduce the sheer volume of patients that nurses would have to interact with. These are challenging rooms. Hospital rooms are kind of grim. They have, if you are coming in with a pain crisis, we saw patients kind of curled into a ball with a light down, trying to stop any kind of stimuli from entering their body. So this was definitely not a place to put anything detailed. It had to be high contrast. It had to be readable from a distance, and it had to be engaging, and it had to look like the people that were in the beds. And that was another issue. We could not find materials that had people of color in them, which is ironic given the disease. So we came up with these 4 design principles. Essentially, there were 2 for clinicians. We have to build something that fits the existing clinician workflow rather than adding something brand new that was going to create burden. And we also wanted to really reposition this whole effort as a collective priority for everyone, not the nurse's job. It wasn't working having the nurses be the front, back, and end all, be all, end all of blood clot prevention. From a patient perspective, especially adolescents, we said we have to give them agency and choice. That's the developmentally appropriate approach. And we also want to give them something that's flexible and adaptive. If you come in for a pain crisis, you're probably going to be there for 3 days. The you on day 1 and the you on day 3 are very different. You're pretty incapacitated on day 1. You're on a lot of opioids. Day 3, you're much more able to get up and do things. So the other thing we were trying to really promote is a sliding scale of activities rather than a yes or a no to activities. So these are the testable interventions we put together. You can see there's a sort of a series of them, and I will explain them. This is the poster. This is the in-room behavioral nudge that we created. Notice that the lower right-hand quadrant down here says get a medicine, and it's got an illustration. And here we use the word massagers to try and improve the attractiveness of wearing the ICPDs. What happened? We put these up. We put up 32 of them in our pilot. I got an email 2 days later from a nurse saying, I have an 8-year-old who will not stop crying. He's looking at this picture of a hypodermic and he is compliant with his movement goals. All he can do is look at the hypodermic and cry that he doesn't want to get a shot. And I've told him he's not going to get a shot. I even took it out and I turned the poster around and put it in so the blank side faced out. And he said, I know what's on the back of that poster. You're not kidding me. So no one wants to hear that their intervention caused children to cry. It's like a bad novel. So we immediately created a new panel, and you can see that the design students are inserting this panel here. So what we decided is to get rid of the hypodermic and instead create an illustration of where they would get a shot, but we didn't change the text. So that didn't pass muster either. The nurses had seen this and they had signed off on it, but I think until it was actually seen in use, they didn't really realize what people were going to imprint on. So we asked the nurses, what do you think would be an acceptable tagline for this? And they said, how about get a medicine? That's what we used. This was a very important panel. Technically, as a pediatric patient, you will not get a shot. So why is there a shot picture? Because when you turn 18, you're no longer pediatrics. You get sent to the adult ward. And it's like going down Alice in Wonderland's rabbit hole. It is a completely different model of care there. So, you know, you're 17 years old and 355 days, and you are in this very loving and thoughtful pediatric environment. And when that 356 days shows up, you go to the adult ward, and the standard practice, if you are coming in with sickle cell, is that you will get a heparin shot, and they're painful. And they said it's really important for adolescents to understand that is coming. So we had to include this component in the poster. So just to summarize, we did this refinement. So two updates in 5 days, and got to something that worked for everybody. We also created this idea of a mobility menu to provide choice to the adolescents. So level 1, which is under the yellow banner, has very simple exercises, and then they move up to more complicated exercises. The idea is we're going to change the conversation. The conversation is no longer going to be, are you going to do some exercises? It's which exercises are you up to today, with the implication that there will be something else tomorrow. So that was the mobility menu. We did create this, no one used it. We also, in our observations, we realized that the turnover in nursing staff is really substantial. This was before COVID. I don't think I understood the degree to which most hospitals, and this is all hospitals, rely on agency nurses, so basically floaters, to come in and pick up shifts. So as it was explained to me, there are 4 hospitals. There's the day hospital. That's where all your standard employees and your best employees go. There's the night hospital. That's where people who, you know, that's where you might fill in your workforce a little bit more with agency nurses. The third hospital is what they call the weekend hospital. That is definitely not well staffed, and may or may not include people who are very familiar with the procedures of that particular hospital. And then there's the holiday hospital. Stay out of the holiday hospital. So these rounding sheets, which are instructions for any nurse for what they're supposed to do every hour, were immediately something we had to update and integrate the VTE efforts into this. We also created badges and buttons to do some social norming. So the idea that everyone wore a button, including the residents and the physicians, that says, I'm a blood clot preventer, are you? This is an identity component. It was built off of a very successful voting campaign you might remember. I'm a voter. The idea that you're not just doing an activity, it's who you are. And we also had these badges that you could put on doorways so that any resident or attending physician who walked in would say, hey, I saw you got your blood clot badge today. Good for you. Here are the outcomes of this particular pilot. We put out a pre and post pilot survey. So we pilot tested for 6 weeks. In the in our preference-based testing, we said, which of the materials improved your effectiveness with adherence of the sickle cell patients, especially the adolescent sickle cell patients. You could see the nurses in-room poster was the top and the mobility menu was the second. Residents, interestingly, a good number of them said none. And that is because we did not succeed or the physician leadership did not succeed in making or engaging residents as part of the blood clot prevention effort. We had much more mixed results on that. Which of these materials helped you feel more confident explaining BTE prevention strategies? In-room poster again. The patient education sheet ranked really well, except we never ran out of them. So I'm not sure where the answer was coming from. But the poster for sure continued to be the highest scoring item on this third one. We put in a little provocative question saying, hey, we're going to take all these materials away on December 7th. So what, if any, would you like to keep? And again, the in-room poster and the patient mobility menu were the top items here. So a question about how effective do people change? This is pre-pilot results. You can see 23% disagreed that they were effective. 23% were undecided. 47% thought they were pretty competent, but only 6% agreed. And you have, worse perspectives here on the resident side. In launching the post survey, you can see that we had a much stronger agreement rate. We lost our disagrees here. We do have more undecideds, but in general, we created a pretty significant bump. I love that the residents actually lost confidence as they moved through, maybe because it elevated their awareness that this was part of what they were supposed to be doing. And then this was important to us. This was not a health system leadership question. This was ours. How supported do you feel by others in your unit? These are the pre-pilot scores. And you can see people, we're sort of on the fence about this, and we got much better post-pilot scores on people feeling supported. That I think we had some success in socializing this idea that this patient care was not one person's issue, it was everybody's issue, and that they needed materials that were inclusive, that were diverse in their use, and self-reinforcing. And I think most notably, questioning the assumption that the change in behavior had to come from the nurses, that people were perfectly capable of changing their own behavior if they knew what to do, which is what the posters were doing. Those posters are still up. This was 2 years ago. We published a paper on it last year. So those posters are still there. For those of you who don't have the joys of doing quality improvement projects, this is called a run chart, not my chart. And what it's doing is on the right-hand side is the documented number of patients who are, percentage of patients who are using their squeezy boots correctly. And vertically is time and the numbers of patients that were sampled at the time. So you can see there was, early before we ever got there, this yellow band. They had created an education campaign, and that did succeed over a course of a number of weeks or months in bumping up success. It then held steady. They did training for how to help pediatric nurses sell these squeezy boots. It didn't create any change. And then our design pilot, which is the green band, brought up about 15 percentage points the success rate of controlling or promoting movement with children in the pediatric ward. And it was a sustained change. That change holds true today. This is the kind of work that I am now doing now that I am back at the Institute of Design. There is a lab that I am running there, an initiative around equitable healthcare. That particular effort, we have federal funding from the Robert Johnson Foundation. I am working with, I'm on an NHLBI, Institute of Health grant, and doing work with the National Academy of Medicine around community engagement. We also have partnerships. Rush and University of Chicago Medicine are both partnered with the Equitable Healthcare Action Lab. And the things that we do include health system advising. It's become clear to me that there's a lot of interest in health systems in employing designers, but they don't know how to do it. They don't know where to put them in the org chart. They don't know what they should be asking of them. They don't know how to measure them. And they don't know who they should be hiring exactly, because are all designers alike? These are the questions that I run into. So being the chief design advisor is a new hat that I am wearing, and I am finding great deal of gratitude in working with them. We're doing care redesign. So place-based primary care is a project with Rush University that we're working on, how to create primary care that people want and will use. University of Chicago, we are working with them on their hospital at home launch. This is the idea of hospitals are, as I mentioned, are kind of dangerous places. If you don't need to be there, but you need a certain level of care, you can technically get that at home through a hospital at home program. So we're helping them stand up their program. And we're also going to be working on advanced care planning and incorporating that as sort of a normal behavioral component of getting care at University of Chicago. It's increasing everywhere, but U of C is the ones that are asking us for help. We do condition-specific interventions. And then, as I mentioned, we have a number of actively funded research projects. And that is it. I am happy to take questions.
Thank you so much, Kim. Yeah, we have a couple of questions that have come in so far. And just a reminder to anyone on the call, if you have a question that you think of, please feel free to type it in the chat. So the first question from Doug is, beyond surveys, are there other effective ways to measure results or change, perhaps follow-up interviews?
Yes, so measurement is an area that design is deficit in. Our measurement's always been the marketplace. If it sells, it's working. If it doesn't sell, it's not working. So measurement in healthcare is something I've spent a lot of time with. I think there are people, we can learn a lot. There are a couple of adjacent fields that I encourage people to look into. One is implementation science. That is medical researchers discovering that there's a lot of effort put into creating things that work in a lab setting, but don't know how to implement in a real world setting, which is something design is actually much better at doing. So we should be partnering, right? But implementation scientists, which are emerging out of the medical field, have a stronger grasp on how to measure and assess the components of an intervention. So you have to ask yourself, are you trying to understand preference? Are you trying to understand whether or not it's been adopted? Are you trying to understand whether or not it is improving patient safety? Are you trying to understand whether or not it's providing or improving patient outcomes? Those are 4 really different categories, and the measurement tools would be different for each of those. I have the great joy of working with epidemiologists at Advocate Health, and my research partners there are tremendous and bring tremendous insights in how to do program evaluation. So I would suggest that as much as we get irritated in design by people who take a weekend course in design and decide they're designers, that we should similarly become more curious about adjacent fields that can take our work and do great measurement of it. I don't know that that's our job, but there are lots of people who would have a point of view about how and which evaluative tools are appropriate. I tend to do mixed methods, so I'll do a quant piece and a qualitative piece. And I find that both creates the evidence trail that I need through the quantitative work, but the qualitative work, as always, explains why you have numbers that look like that. Surveys are one thing, but I think that we need to be more systematic about understanding what it is we're trying to measure, what we should be measuring.
Great, thank you so much. We have a question from Caroline. How do you get buy-in from providers or payers for design projects like this?
Buy-in, yeah. At this stage in my career, I only work with the willing. That's how I get buy-in. You build a coalition of people who believe that there's a better future out there and want to do whatever it takes. So I would ask a different way. How do you put up a bat signal in an organization to attract people who are ready to work differently and work with them? And as you work with them, create proof points that begin to disseminate throughout an organization and allow other people who are not early adopters to come over and express some interest in maybe working with you. I have very rarely succeeded in evangelizing design. I think you look at something that works or obviously is better, and most people go, yeah, that looks like a good idea. So I think that the idea of selling up front is probably not your best strategy. I don't find it very successful.
I think that's incredibly interesting how you put that. So I had a question that someone submitted to me instead of to the general chat. So how did you personally make this your specialty? Did you have a background in medicine, or what drew you to this field?
Yeah, so that's for me, that's interesting. My focus has always been communication. I was in journalism before I came to get my master's in design. And when I was mostly political journalism, and so, sort of paid to watch the Senate. And one of the things that became really clear to me is that there were such important, really important ideas that were failing to connect with people. And partly that was because they were complicated, and partly because of the way they were being disseminated, and partly because there's a lot of things to pay attention to, and so it's hard to make it up the top of somebody's priority list. So my focus has always been communication and connecting people to information that they need. That's what I did that's what I studied at design. That is what I taught as a design professor. I wrote a book on it. In 2013, I wound up being invited to a meeting of 40 some odd people who were kicking off a grant in Chicago that was trying to understand how to keep kids coming back to the emergency department with asthma attacks. And there had been an evidence-based intervention from Canada that had tremendous results, really outstanding results. And I'm sitting in this meeting going, I have no idea why I'm here. I do not have a background in medicine. My mother's a nurse, but only go so far. And then they passed around this intervention. They're like, we're going to do this in the study. And I looked at it and I was like, I now know why I'm here. I don't know why this produced the numbers it did, but it's not because of the usability, clarity, or relational quality of this content. And so the principal investigator, who probably also didn't understand why I was there, I met with him afterwards and I said, this is a disaster. I would not put this into a randomized clinical trial. And he said, well, what would you do? I said, I would go talk to the people who use this thing and figure out how to make one that's appropriate for the low-income families in Chicago. And that's what we did. So he basically gave us a year to prove ourselves. What we did is we said, look, this is a design process. We're going to go into people's homes. We're going to spend a couple hours with them. We're going to learn what they do after they bring their child home from the emergency department. Where do they keep their medications? How do they create a medication regimen? Who's actually in charge of that medication? We're going to ask them all these like really basic questions. And then we're going to go to the emergency department and we're going to see how this thing is actually used in real world practice, because there's a whole difference between somebody sitting down with a highlighter and saying, this is important, and this is important, and this is important, and somebody handing you a piece of paper without talking about it. And then we're going to go to outpatient providers and we're going to say, hey, you're downstream of this whole emergency department episode. What is it you wish your patients were being told when they go to the emergency department? What's the life-saving advice that you want them to hear? And let's put that in this document as well. And so by sort of doing a multi-stakeholder 360 review of all the users involved in this, we came up with a number of insights. So not only did we come up with a better intervention that did go through a randomized clinical trial and did produce dramatic results in what they call process measures, which I'm very proud of. But we also observed that the whole premise of the trial was that physicians were going to be using this document to discharge patients, and that physicians were not going to do any such thing. So it became really clear. I said, you need another person to be giving this out. And they redesigned the trial based on our observations. At that point, that physician, that principal investigator, who is a renowned pulmonologist, said, can you do more of that? I have other studies I'm doing. And I said, I don't know, let's figure it out. So from that point on, he was a champion. That's what I'm saying, put up the bat signal, found somebody who was willing to let us work differently, watched us create enough clearance for us to do that, but integrated us into the team. I was at every team meeting on that. I was not the ancillary designer off to the side with my team. We were at every meeting. We were giving reports. They were responding to the information we put in. That's a willing stakeholder. And that was the beginning. So once we did that, we were introduced to, it was in every health system in Chicago. And we have a lot of uptake. Our partnership with the University of Chicago is terrific because, again, it was a group of people internal to the medical center who said, we need people to work differently. And I was like, I'm happy to help. What can I do? And so, they signed me on and we're figuring out together. I have more people asking for our help than I have hours to give. So when an organization is ready and the leadership is right, there is a potential to do dramatic things, to do important things. The question you're not quite asking yet, but I wish people would understand, is that this is a different kind of design. And it is a subspecialty. I do encourage people who are designers who are interested in learning to work this way, that they have to learn to work at the systems level. I'm not quite, there's apprenticeship models to do that, going back to getting an MDes or getting a refresher course. It's a different level of work.
That actually, your answer actually leads really nicely into the next question we got from Todd. He is an ID grad from the class of 2020, and he is an in-house designer at Kaiser Permanente. And he asks, do you have any advice for working in an in-house capacity and increasing speed to execution to trial in a project like this?
Yeah, that's a tough one. Having been in-house as well. Look, medicine is different. And I think that part of it is a adjustment of expectations and an adjustment of skill set to address the fact that the scale, the scope, and the speed of change in healthcare is slower. Speed is definitely slower. The scale is larger. So even a tiny success can have an enormous impact on an enormous number of people. And then the scope, which has to do with how do you bound a problem? And we're all trained on user-centered design. Well, there's not a user here. There are many, many users and many different types of users in many different settings. And so the scale, scope, and speed shift is something that I think we all have to wrestle with to adjust our expectations. That said, again, I think the way to create proof points, you need proof points. Proof points will lead to bigger projects. So how do you find projects and people that you can do, just as we did in this particular project? It was a 6-week discovery phase and a 6-week data collection and a pilot phase. That's because people knew they needed to change. So another thing to do is to figure out what the strategic initiatives are for the health system. Those are typically published every year. They have a 5-year strategic plan. Go find something that attaches to that. Find somebody at the top who cares about something and go find how to connect to that person. Because if it's a health system priority and people are being paid for performance on that, that kind of opens doors as well too. I don't know, Todd, that's probably a pretty obvious answer.
And I think our last question is from, I think it's Eliza. And she asks, is there a way that she can get in touch with you or learn more from you and your team? If you'd also like to share if there's any opportunities for visiting students or, summer sessions coming up that you'd like to share as well.
Yeah, I'm happy to talk to anybody. That's the truth of things. So my email address is on the website at the Institute of Design. Please just email me.
All right. Well, great. Thank you so much, Kim. This has been incredibly interesting. And again, just a reminder for everyone on the call, this was recorded and this will be up on our website if you'd like to watch it again or share it. And we hope everyone will join us for our next Alumni University session, which will be on April 20th. Lulu Kang is going to be talking about vaccine equity. So you can sign up at iit.edu/alumni university. So thank you again so much, Kim. We really enjoyed it.
Oh, thank you. And thank you for everyone who joined. I see now, I'm looking here that these are so many ID graduates. It's such a nice thing to hear from people. Have a good night, everyone.